series is Dr. László Entz. He is the Chief of Surgery at the Mind Clinic in Budapest and the Senior Attending Neurosurgeon at the Hirslanden Clinic in Switzerland. Many years ago, or a few years ago, Dr. Entz was an HMAA fellow here in Buffalo. After completing his medical school training in Switzerland, he would go on to do a residency program and specialize in neurosurgery. Was also a Fulbright scholar. Spent many years under the tutelage of a former speaker of ours, Dr. Eros Laurent, learning about functional neurosurgery as well as neuromodulation for the treatment of back pain. He spent 5 years in Switzerland at various clinics, learning about minimally invasive and practicing minimally invasive spine surgery, and is now back in Hungary at the Mind Clinic as a chief of surgery. Without further ado, Dr. Entz.
Okay, thank you for the great introduction. Let me share my screen. Is it good or no?
If we can get the presentation mode.
Maybe I have to start it a second. Do you see my slides?
Perfect.
Okay. Good. Yes, so thank you for the introduction, and I let also everybody greet. You can read my topic, which is revision spine surgery or neuromodulation in patients with failed back surgery syndrome. Now, the first thing is that failed back surgery syndrome is not really appropriate anymore for many reasons. There is great discussion in the literature about what would be better. The most recent suggestion was instead of failed back surgery, persistent spinal pain syndrome. I will come to it a little later. I have no conflict of interest. So why not failed back surgery syndrome? It's misleading, first of all, especially for from a surgical point of view. It would suggest that we did something wrong. It failed. The term actually is much more relevant in terms of postoperative pain, either recurring pain or not completely diminishing pain after the spinal surgery. So there is a great deal of discussion about it. And in the last ICD-11 nomenclature, they changed it to chronic pain after spinal surgery, which is also not so good. So from the point of view of the pain physicians who are dealing with these patients, the suggestion was this PSPS. They also made a categorization, a new categorization, which I think really good reflects the meaning of this whole patient group. They said there is a type 1 where actually a surgery was never performed, but the patients do similarly to those patients who are, in older terms, failed back surgery. So after performing it, after having a surgery, they can have very, very similar symptoms due to typically degenerative spinal disease. So that would be type 1. And then type 2 reflects the older term as we used to name it and use it. So I found this little sketch on the internet: avoid failed back surgery syndrome, choose a non-surgical approach. According to this new nomenclature, you don't even have to have a surgery to have failed back surgery syndrome. What is it? There are patients who are doing very well after spinal surgery. We know that the most effective spinal surgery is a microdiscectomy. About 90% of the patients after microdiscectomy are absolutely long-term pain-free. There are very good data on how effective fusion surgery can be in subgroups of patients, but the overall satisfaction is also in monosegmental disease around 60–70%. But some patients just not do well. What is the mechanism behind the pain? And we have to see that, of course, we can have the anatomical problems after surgery. So we can have pain coming from the vertebral column, which can be a new discogenic pain, a new herniation, a facetogenic pain, which is maybe in an adjacent level, or even the SI joint could be a source of pain. So that's also a sign that not necessarily the operated segment is the problematic in so-called failed back patients, because maybe the operation was done perfectly and the problems are arising in a different segment. Of course, the pain can arise from the nervous system. We have the nerve roots, which are typically causing pain. There can be adhesions, irritation of the nerve roots, or even a new nerve entrapment later on, and most importantly, neuropathic pain due to either damage of the nerve due to, for example, a herniation, or even surgical iatrogenic cause. Very important is central sensitization. Pain patients, especially chronic pain patients, also before having a surgery can develop a central sensitization, which is very difficult to handle if it persists also after the surgery. Many times also physicians who are treating these patients, which are typically pain physicians, orthopedics, neurosurgeons, neurologists, etc., are not really paying enough attention to the muscles and fascia. We can have myofascial trigger points. For example, a gait abnormality can cause mechanistic or muscular pain, and many other elements of the muscle system can also contribute to the pain of these patients. A very important factor are the complications of surgeries. I will show a couple of cases. An infection or hematomas can cause a secondary damage, especially of the nerve roots or nerves. If this happens, this can be also a source of pain. And very, very important is the last point, psychosocial factors. We can't probably stress enough how important this is. So if you have a depressed patient who is not treated, then the successful rate, either for classic surgery, fusion surgery, for example, or neuromodulation, is much, much lower, significantly lower compared to those patients who doesn't have any psychological disease. So in that sense, finding these psychosocial factors such as depression or anxiety then is a key factor in treating these patients. It's very, very important. For neuromodulation, it's also obligatory, for example, in Hungary, to rule out any of these diseases. So the epidemiology of these, the syndrome is, you can say, about 25 to 50 patients on every 100,000 citizens in the UK, and much, much higher in the, this is the spinal surgeries done in the UK and in the US. You can see how much higher the number is in the United States. Now, this is a very, very important figure. 5 to 36% of these patients who had surgery have residual pain after 2 years. If it's the old pain or the new pain, that's another issue. I will come to it. But these patients, a big percent of these patients have some sort of pain. So this is a very big number. You can also see the importance. We love these figures, the number of publications. There's a number of publications for the term failed back surgery syndrome. It peaked in 2020, maybe it will even go further on in the coming years, but certainly we need to treat these patients. What are the options? I think the most important is, I already said in the beginning, to treat these patients on a multimodal way. The problem is with the data that's why the results are not that good, because we are trying to categorize these patients into one of these management strategies. The first is, of course, conservative medical management with physical therapy, medication, even psychological help. It's always the first step, no doubt. It's very, very important, and I think many of these patients can be helped conservatively. Then if I go further on, according to the invasiveness of the other treatments, epidural adhesiolysis or epidural injections are also, I think, a key factor in the treatment of these patients. I don't want to spend too much time with it today, but I think the results are sort of statistically probably the best for adhesiolysis in this patient group, which is explained with the adhesions postoperatively in the spine. And this is a minimally invasive procedure, so I think the patients should almost always try this before having a major surgery, revision surgery. Neuromodulation is of course a very intensively growing field of pain medicine, which is good because it's a reversible technique. It's non-destructive anymore. It's low risk, and many patients can benefit from the use of neurostimulators. I will come to this a little later. Revision surgery is in the last decade, especially because I think minimally invasive pain procedures and neuromodulation developed so much, is less and less done today. It has its reasons. The revision surgery successful rates, outcomes are not that good in a general population, but this is the point what I would like to do. If we select the patients correctly, then a revision surgery can be extremely helpful for the patients. Some statistics, I don't want to spend too much time with statistics, but I think it's necessary to see. We have a couple old studies for SCS, spinal cord stimulation, which are RCTs, and these are the strongest evidence for neuromodulation in failed back surgery syndrome. The Kumar study, which showed spinal cord stimulation compared to conventional medical treatment in failed back surgery syndrome patients, a clear evidence of benefit for spinal cord stimulation. 48% of SCS patients compared to 9% achieved the primary goal. So this is still the strongest evidence for SCS. There's the Norse study, which is very interesting for this talk, because they compared spinal cord stimulation in FBSS to reoperation, and the success rate was 47% compared to 12%. So this showed a clear evidence for leg pain, and I would like to stress it. This is done for leg pain, and low back pain was ruled out from the study. So I think this is clear for a neuropathic radicular pain. SCS will be always better, or at least for a bigger group of patients than reoperation. These are just to have an overview what is spinal cord stimulation meant for today and what is the evidence. So we have class 2A evidence for failed back surgery syndrome, for SCS, for leg pain. And these are the other indications for spinal cord stimulation, CRPS, or even angina. But what is important that other neural disorders such as postherpetic neuralgia or diabetic polyneuropathy could be an indication for spinal cord stimulation. A little bit about the statistics of epidural adhesiolysis in PSPS or FPSS. There is an RCT done which compared epidural adhesiolysis with the catheter and epidural steroid injections. And it showed that the epidural lysis showed an effectiveness of 50% in compared to 5%. So I think this is a very important tool what we have here in our hands to treat these patients. And this is also the strongest evidence in FPSS with the best results. There are some other studies basically showing the same results, at least for 2 years. This pain reduction is still persistent. Now let's talk about the repeated operations. These results are not really promising because the patient recruitment is more general and not really looking at the individual needs of the patient. So if you see 35% of the reported, 35% reported a good outcome in the first group from 100 patients who got a revision surgery after an initial spinal surgery. There is another group who initially had 80% a good satisfactory result, but it went down to 22% already in the midterm follow-up around 2 years. Another study from Markwalder, they looked at 2 years outcomes, revision surgery stabilization after diagnostic procedures, and this is very important for instability. So this study already looked at the etiology of the pain source, which was in that case instability, and spinal instability is a very good indication for revision surgery, and you can see already very good results in basically almost 80% of the patients after 2 years, because instability is also, in my point of view, one of the indications for revision instead of neuromodulation, for example. Now, these are the recommendations. As I said, epidural adhesiolysis has the highest recommendation, and revision surgery the least. It's basically not recommended according to the evidence out in the literature. But the daily routine, I think, is not that simple. If you look at the different therapies, what is a positive expected outcome according to the data, then we see 50 to 70% with epidural adhesiolysis, SCS around 50%, infiltration and surgical revision around 1/3 of the patients. If you change it and look at it in another perspective, then we see what's the negative expected outcome. And the negative expected outcome is the opposite, of course, which shows that we are not doing very well with these patients, because the whole group has a very great majority who is not treated well, even using these methods. So we have to be better. And I think how we can be better is the indications for the different modalities. So let's go to the surgical point of view. What are the indications? In my opinion, for example, progressive deformity, sagittal or coronal disbalance, it's certainly one of the indications. Spinal instability, as already I mentioned. Pseudoarthrosis is many times not diagnosed. It's very seldomly diagnosed, at least what I see in patients. I had the chance to work with Professor Dezső-Jeszenszky in Zurich, and he's a specialist of revision spine surgeries. And there I had the chance to really learn how to diagnose pseudoarthrosis. And I think it's highly underdiagnosed. Of course, if there is still radicular compression, it needs to be operated. So let's talk about real cases. This is a case from the Schultes clinic from my friend and colleague Markus Leubel. There is a patient, 57 years old. When he showed up in the clinic, you can see the list of his surgeries from 2005 to 2015. And when he arrives, he shows this X-ray. This is a whole spine X-ray showing a clear problematic of the sagittal balance. He has a high low back pain and also radicular pain L5. Therefore, he got a neurostimulator to treat that, which is working to some extent. So he's better with the radicular pain when the stimulator is on, and he has 50% unable to work. The sagittal and the coronal balance, if you look at the images, but mostly the sagittal balance is clearly out of balance, and the lumbar lordosis, instead of around 60 degrees, is 20 in his case. There are now many tools what we can use to correct for the sagittal balance. One of them is the gap score. I don't go into the details. It's very complex. You have to do a lot of measurements. There are already automated ways to measure it, which shows how much this patient is severely hypolordotic. So what can we offer to this patient? This would be the actual state. This would be the state without the compensatory mechanisms, the muscles basically. And this would be the ideal state for him. So we have to bring him from this state or this to this in order to treat his back pain. How you can do it, I don't want to go too much into the detail, but I think many of us doesn't ever heard about these kind of operations, osteotomies. There is a method called pedicle subtraction osteotomy, where we basically perform osteotomy within one vertebral body. We remove the pedicles. After the procedure, two nerve roots are exiting basically in one foramen, but this allows us to close this gap and put the patient back into his almost normal lordosis. You can see that the surgery was performed with his patient, or the fusion was already also extended to the pelvis, because you need to have a very good base of the fusion in these cases. And if you compare the two X-rays, you can clearly see that the sagittal disbalance is mostly corrected for. It's still not normal. It wasn't also the goal, because that would be an overcorrection, as the data said. But the big portion of the deformity is corrected for. After the surgery, he has a low back pain of 1, 2. It's about 6 months after surgery. And also his L5 pain reduced to around 3 without stimulation. He can work 100%, so he's absolutely able to work again. He got his life back, and his neurostimulator he wanted to have out because he basically didn't use it anymore. And we have, of course, evidence for this, that the relationship between the sagittal balance and clinical outcome for degenerative spine disease is clearly there. Another patient, a patient with one of the most frequent operations, an ACDF, an anterior cervical decompression and fusion with a radicular pain between C5 and 6. This was an absolutely unproblematic operation, and this was, and the patient did very well after the surgery. But around 2 years after the surgery, he started to have again pain in her neck. This was the postoperative CT scan 2 years after the surgery. It shows at the first look consolidated the situation. The cage is sitting well, no loosening. There is some hyperdensity around the cage, but I wouldn't even see it as there would be a problem if the patient wouldn't have pain. But the patient had pain, an unstable feeling in the neck, fluctuating pain with pseudoradicular components. So the question was, what can we do? Of course, conventional medical management was started, physical therapy, all didn't help at the long term. So we decided to perform a SPECT CT, and after 2 years, this was the image which shows a absolutely high activation of the operated segment, which is a clear sign of microinstability and non-fusion, which is pseudoarthrosis. So we decided to operate this patient. We did a revision surgery. We changed the cage and put a plate on it, and the pain immediately diminished. So this is the postoperative image. You see in this operation, we also put an extra plate to stabilize the segment even further, but the cage was also changed. So this is something I think where we have to be better. We have to diagnose pseudoarthrosis much aggressively and much better. And if this is the problem, we could actually, for the unknown source of pain, recommend these patients also even to have SCS or neuromodulation, because this would probably help to some extent. But until this nociceptive component, this mechanistic component is not solved, I think this patient would not do much better. So now let's step over to neuromodulation. The strongest evidence for spinal cord stimulation is for failed back surgery syndrome or PSPS. I think this is quite clear why, but we have to know what type of pain do we treat with neuromodulation. And of course, neuromodulation will not be good for a clear mechanistic pain. It's good for neuropathic, especially radicular pain. Or even neuropathic low back pain, which is getting more and more sort of high evidence in the literature, and also if we have a lesion in the nervous system, either in the central myelopathy, for example, or in the radicular part, this is very, very important to step for neuromodulation. Just a little bit about how it works. There are every day almost new articles about the new waveforms, but still it's important to see the three basic ones. This was the first one, the tonic stimulation, where we give around 40 to 60 hertz stimulation. Then it was followed by the burst stimulation, where we give burst packages of stimulation and then a little stop phase, or we can give the continuous around 10 kilohertz stimulation. Tonic stimulation is typically suprathreshold. What does it mean? It means that the patient feels the paresthesia, which should cover the painful dermatome. That's how it works. For some patients, it's unpleasant. That drives the industry to develop new techniques, but in some patients, it works very well. Burst stimulation is already a sub-threshold stimulus, so that means that's paresthesia free. There are these different frequencies, and it may address both the somatic and the affective emotional pain with the tracts going up to the brain. And then kilohertz or high frequency stimulation is also a sub-threshold stimulus. It's very convenient for the patient because they just don't feel it, that it functions. And more and more studies arise with high frequency stimulation for low back pain. Probably this will be one of the solutions for the future. There are many aspects besides the frequency what we can change during our therapy. It's very important that we can shape the electrical fields with cathodes and anodes, because sometimes the electrodes, some of the electrodes are needed for the pain control, and the other ones are maybe unpleasant because they're stimulating the nerve roots. And now we can use advanced programming to steer the electrical field. There are new stimulators which have independent current sources, which allows us an even wider broad of settings to have the optimal stimulus for the patient. We have to also know the electrophysiology of these stimulus. What are we stimulating? There are at least these 4 structures which we can stimulate: the dorsal columns, the dorsal roots, the dorsal horn, or the dorsal root ganglion. Even in the foramen out, you need different electrodes to use this kind of stimulation. I don't want to go into the details. I just wanted to show that there are many aspects of neuromodulation which we can still sort of focus on and do research on, which is the better for which kind of patients. This is just an example how many trials are actually being performed or actually running or actively recruiting for this kind of procedures. One of the research aims is always to find new targets and new indications for neuromodulation, and many of the trials focus on parameterization, how you can optimize the stimulation effect. Now another patient which shows that neuromodulation is good, but not for everybody. Here is a 78-year-old female patient who had osteoporotic fractures from L2, L5. It was operated as it had to be in order to reduce the instability. Patient got to a certain extent better, but the osteoporosis was not healed. So she got new fractures above T12 to L1. As you can see, the patient is obese and also generally not in a very good condition. And she got to a pain therapist who decided for this clear sagittal disbalance to try SCS and implanted the electrodes at his pain clinic. And you can see the patient is 17 centimeters disbalanced, and also coronally 6 centimeters. And as we expect, even high frequency stimulation with this kind of deformity cannot be successful. And the patient basically had no pain reduction. The problem is, what can we do with these patients? Because a revision surgery is also not an option in this state, because she needs a better osteoporosis control before. So for the time being, for example, with Forsteo, the patient is pre-treated and she can be implanted again. We basically have nothing else, just conventional medical management and maybe medication. But this is clearly a bad indication for neuromodulation. Now there is another interesting case. I don't have clear-cut cases for neuromodulation because it's obvious. It's not the point of this talk to show patients where there was a clear indication for a monoradicular pain and we implanted and it worked. So this is also an interesting case. The patient had several surgeries, which caused later on an epidural abscess, an infection in the spine, which needed to be stabilized because of the instability. So the patient got L5-S1 hybrid spondylolisthesis, which reduced his back pain, but the patient developed, due to the infection and the many surgeries, also neuropathic pain. And the neuropathic radicular pain was about 60%, and the mixed neuropathic and nociceptive pain was about 40%. What happened? Because the pain was, of course, disabling her quality of life. The patient got in 2011 a minimal invasive pain intervention and epidural lysis, which is a nice try, and the short-term result was good, but long-term the pain recurred. So what happened is, later on he was tested with SCS, which reduced nicely his leg pain significantly, and during the test phase, the patient said it changes his quality of life so much that despite the back pain is still present, he would like to have the neurostimulator. Now, this is the X-ray of this specific patient. What you can see is that there is sort of a paradoxon, because spondylolisthesis is typically a situation where the segment gets unstable. The surgeon who operated this patient tried to reach fusion ventrally and implanted a cage, which is correct, and then implanted the screws as needed, but then he got, instead of using a rigid rod, he used a peak rod, which is somewhat elastic. So it's a hybrid fusion, which is, to my point of view, a bad indication for this kind of patients, because it leaves some sort of a movement in the back in a patient who needs stability. So I think this is the problem why he still has his back pain, and even with SCS, it's not manageable because of this mechanistic problem. So the question is how we treat it, and to my point of view, I would just make a revision with the same segment, not going further, and the patient would probably feel better. There are also other options, just to highlight it, what can help us. There are even machine learning AI algorithms which can predict the response to SCS instead of lead screening. So this is the future. We will give all the data of the patients to a software, and then it will tell us, is this patient amenable for any kind of neuromodulation or not. This paper is coming from Philippe Rigoire's group and a bigger group who is very, very active in this field. I think we will, in a couple of years, only use these kind of predictors to see which patient is good or not. It's coming slowly to the end. What is the real life? I just got today a referral from a colleague for a 63-year-old male patient who was several times operated and also got a progressive spondylodiscitis, an infection in the spine. And to his bad situation, he not just had that, but it was everything happening before the COVID started. So he had the hardware had to be partially removed, and an antimicrobial therapy was used to heal the infection. But then at the times of COVID, he couldn't be operated, so he had to suffer extreme low back pain with pseudoradicular components. And now I will show the actual CT image of this patient. You can see the bony defects, the vacuum phenomenon, the completely loosened screws in all the three segments. Now we have this patient who is healed from his infection, but clearly has dramatic mechanical problems. Theoretically, if you look at the literature, we could even recommend neuromodulation to try it, because there is evidence that it will work. This is a very complex surgery to deal with. If you want to do a revision surgery, you have to deal with the adhesions in the spinal canal, and naturally the bony defects. You have to do a corpectomy. You have to reimplant the screws. Most likely have big screws also in the pelvic, and even go further higher to have a stable situation. So this is where we need our colleagues, and we need the patient on board, and we have to find an individual solution to this patient. What can we offer to this patient? We will see what happens, but as a summary, I can say that the treatment of FIPP surgery is complex, and it has to be multidisciplinary, and the indication has to be individually based. According to the literature, epidural thrombolysis and spinal neuromodulation is what you can actually recommend. Revision surgery, according to the data, not really. But despite in the presence of clear spinal pathology, or implant failure, I would suggest to review the films and see the patient, and in certain cases do a revision surgery. But you have to have adequately chosen surgery, which can give the patient a long-term pain relief. These surgeries are very difficult. It needs surgeons and teams who are especially trained in revision surgeries. You have to understand the pathology in 3D space, how much you have to correct the sagittal balance, how much you have to correct the bony defects, how much you have to deal with scarring and releasing the nerve roots. It's very difficult, but in good hands, you can have extremely good results. Complex treatment strategies are needed. The best results, I think, can only be achieved by combining these modalities. So even a good revision surgery doesn't work if after the surgery the patient doesn't get the support he needs from the physiotherapist, doesn't get very good medical therapy, and especially in cases where we have mixed pain, which is almost always the situation, if there is a residual neuropathic pain, then maybe we have to offer the patient a neuromodulation after the revision surgery for the residual pain. Take-home message: treating PSPS is not easy. It always needs multidisciplinary board in situations where it is available, and always try to combine the modalities. Adequate patient selection is needed for successful revision surgeries. And we have to keep in mind that neuromodulation is getting better, and maybe this is the future for this kind of problems. But I think some cases we always have to stick also for the classic surgery. Thank you very much for your attention.
Dr. Entz, thank you for that. I think we'll now open it up to chat to some questions. It looks like there's one in the chat box. I have two questions. One, does MRI have value in the diagnosis versus CT? And two, how do you ask for an appointment in Budapest?
So MRI is critical. Without MRI, it's extremely difficult to diagnose such problems, because MRI gives us the detailed information, especially of the nerve roots, of infections, and the fine structures of the spine. For these complex cases, we need both. Typically, we need a CT scan. Also, if there is also already a surgery being done, because the CT scan shows us the implants and the bony structures better. So imaging is crucial, as well MRI, as well CT, we need both of them.
Wonderful. And then the second part of their question was, how do they ask for an appointment in Budapest?
Just call Mind Clinic. I am available through Mind Clinic.
Wonderful. So that's mind.hu, and I believe we can schedule appointments for you online as well.
Yes, exactly. Through the web. It's already. I'm still not. Website. Yeah, exactly.
Wonderful. Now we have another question from Buffalo. Thank you, Tanya. For how many years post-operatively is contrast ordered with MRI?
Contrast is. I couldn't say a year. It depending on the situation. If it's early postoperative state, then we always give contrast agents to be able to see what is an enhancement, a pathological enhancement because of, for example, an abscess, an infection, and this is the best way to rule out. Later on, I always perform initially years after the surgery, 2 years or 3 years after the surgery. I initially do just a native scan without contrast agent. And if there are questions which arise in my head, then I will decide upon what I need for. Because typically, if there is no active infection or scarring, then a CT scan would be a good complementation, or even SPECT CT. There are many other modalities which we have to use in order to see what's the problem. So there is no rule of thumb for me. Initial postoperatively, yes, definitely. But let's say after 6 months, not necessarily.
Perfect, thank you. Are there any other questions for Dr. Entz from the crowd?
Thank you very much.
Well, it seems like there's no other questions as of yet. I'll take this moment just to remind everybody to receive CME credit. Please send me an email with your full name and your email address. I'm going to put my email in the chat. Our next series is scheduled for next month on the 22nd. We look forward to seeing everyone there as well.
There's one more question. Coronal CT taken the best to assess for pseudoarthrosis? Not necessarily. If we would like to diagnose pseudoarthrosis, we certainly need an X-ray, CT scan most of the time, and also an MRI. If it's a clear loosening of the screws and pseudoarthrosis is an easy one, then you see it even in a plain X-ray. If it's something like I showed before with the cervical spine, where the X-ray looks good, even the normal CT scan looks good, then on the MRI you maybe see some changes in the plate, end plates of the vertebrae. Then you need a SPECT CT. So there is no one way to look at it. You need to look at it. You have to use all the imaging modalities you need for. How about painkiller? I didn't really went into this topic, and necessarily you need medication in every situation. And this is the first thing what you do. You have to use painkillers for the acute pain, acute phase. But I would say if painkillers doesn't help you for an acute phase and the pain still persists longer than 2-3 weeks, then you have to start to think about some chronic treatments which help you on the long term. I think there is no, for which problem, because we have different medication for a neuropathic pain, a completely different group, anti-epileptics or even antidepressants for neuropathic pain. If it's a nociceptive pain, then we can start with the typical paracetamol and Voltaren or so diclofenac, etc. And if the pain is really bad and high, then you have to even go for opioids. Some patients take opioids on long term. This is also a reason why we have to do something after a while, because there is clear evidence that we can reduce the opioid intake if you start neuromodulation or do a good revision surgery. So there is no one special medication what I would recommend. It's very individual. And many times you can do minimal invasive pain procedures, just a nerve block, for example. It can help absolutely for months in some patients. I have patients, which is also a very important part of the therapy.
Any further questions from the audience?
Great questions, by the way, because this is the way to look at the patient. What can we do? What kind of sequences? What kind of imaging? What kind of medication?
Well, Dr. Entz, thank you again for that wonderful lecture. It doesn't seem like we have any further questions from the audience at this point. If they do, they'll just send me an email. I'll follow up with you that way. Thank you again. Everyone enjoy your weekend and go Bills.
Thank you.
Thank you. Have a great weekend.
You too. Thank you.
Bye-bye.